Uh, I'm sorry. I'm the chair of the healthcare roundtable for the local League of Women Voters, the Piedmont Triad. And Rebecca Cerese is our speaker today. Her title is Health Engagement Coordinator with the North Carolina Justice Center, which is
Actually, the health policy advocate. That's
okay.
an old,
Oh,
yeah.
Olben. Okay, so
Yeah.
she is the health policy advocate at the North Carolina Justice Center. And it's worth spending time on their website just to see what they're all about. For the past 5 years, she's been involved in something called the Health Advocacy Project that I've been using stories about how people have suffered under lack of Medicaid expansion, and of course we are now celebrating the final passage of that and trying to keep some track. Rebecca will, I'm sure, touch base or tell us more about that. Um, she's also a founding member of the North Carolina Medicare for All Coalition, which is the website I mentioned, and it's committed to promoting a universal single payer health system that puts patients over profits. Now, I have to say that Rebecca is the whole reason that the whole thing hangs together at all and keeps it going. But our roundtable is one of the supporters of that. So I'm going to go ahead and turn it over to Rebecca and have some time for questions and answers later on.
Absolutely. And, we could do questions and answers at the end. Or if there's something pressing, I'm very flexible. So thank you so much, Wayne, for inviting me. So I am just a passionate healthcare advocate, period. I'm lucky enough to do this for work at the North Carolina Justice Center, where we for the last 5.5 years, have been pushing to expand Medicaid as our top priority. We were able to get that done, and then it went live on December 1st of 2023, and I'll talk more about that. Priority for this short session coming up. So the Health Advocacy Project at the North Carolina Justice Center, we do a lot of work, but a lot of it is state-based. And one of the things that's coming up in the short session, the short legislative session that's going to be happening in April, is potentially a bill called the Medical Debt De-Weaponization Act, which is trying to put protections for patients around medical debt. We know it's a giant problem in the Medicare for All work. It's one of the things that I definitely push on, that we are the only developed country that allows people to go bankrupt because they got sick or had an accident. Most people who are facing medical debt actually have insurance or had insurance at some point during the whole process. So the medical debt issue in particular is just a demonstration point about how dysfunctional our system actually is, and how it actually isn't working for so many people. So while I'm working on trying to make these smaller fixes and encourage people to do that, where, the main goal, the end goal, is to actually transform our profit-based healthcare system to a single payer universal healthcare system that actually puts patients over profits. But there's a lot of things that we can do along the way to be pushing us in the right direction there. And that's one of the things I'm going to talk about. So, of course, 2024 is an election year. And I know that we're all, nonpartisan here, but we want to get people excited about voting. One of the things that I have found just doing this work is that there's a real disconnect between voters understanding that who they actually put into office is making the policies which directly impact their lives. So I think one of the important things that we can be doing when we're out there doing canvassing or get out the voter registration is to make those connections for people. You don't have to tell people who to vote for or anything like that, but just to be like, the people that you're going to vote for, from every level of our government, actually make decisions, make policy that actually directly impacts our lives. And that it is our role as, civically engaged people to actually talk to candidates about the issues that matter to us, the issues that we care about, especially if, you have a level of expertise in your issue. you know, whether it be through school or through your own research or anything like that, we have a duty, I would say, to actually talk to our candidates about this, because I will tell you, most candidates cannot be or elected officials cannot be experts in every area. Okay. And so it's very, very important that they hear from us and then from other folks, especially if it's something we really want to move on. Obviously, this is where grassroots organizing comes in, you know, that we can actually do grassroots organizing around these issues. And I think healthcare is just something that is so widespread. It's something that so many people have had an experience with, you know, either directly or indirectly through a loved one, some sort of experience with our broken, dysfunctional, cruel, profit-based system, and are more open to hearing about you know, what's going on and possible solutions. And even if they're not ready to hear like the universal single payer, you know, messaging, there's ways that we can lead up to it. And I also even think that there's ways we can talk about that, where that can help break down walls instead of build up barriers. And if that means messaging in a certain way, where we're not using the terms Medicare for all, that's fine. I mean, we have to be strategic in how we talk about these issues and how we you know, communicate on them. Um, I will say that one of the things that I think is something we can be pointing to is Medicaid expansion. So, you know, we did something amazing in a divisive political climate. We finally, after 10 years, but still did it legislatively, we actually put forward a massive expansion of health coverage in North Carolina with Medicaid expansion. This is something that we can engage with people about. This is something we can talk to people because yes, the wonderful thing is on day one, December 1st, you had about 260,000 North Carolinians that were auto-enrolled from what was called a family planning Medicaid benefit into full Medicaid benefit. But there's still many, many more North Carolinians out there that do not know that this new healthcare option is an option and or how to enroll in it. So I wanted to just take a few minutes, and actually I will probably just share the screen because I just want to uh, actually show just a little bit about how to talk about Medicaid expansion. Let me see, why can't I find the way to share the screen? Because I know you gave me that. Huh.
Not down at the
Green.
bottom.
Right there, green. Got it. Okay. It was green. I don't know why I wasn't able to. Okay, so let me do slideshow from current slide. Okay. So I'm just gonna, and I'll make sure that you have a copy of this PowerPoint if you're interested in it. But so we were the 40th state to expand, over 300,000 already have it. So just a real overview, it is a comprehensive health insurance program for people with low incomes that's jointly run and paid for by the federal government and the state. And a lot of people already rely on Medicaid, especially children, but now even more people are eligible. So we believe it's the best health insurance plan in North Carolina. And in fact, the people who support a single payer universal healthcare system, Medicaid is actually closer to what we're talking about in a lot of ways than what Medicare is, because very low out-of-pocket costs. In fact, the highest copay you can pay for a Medicaid service is $4. So very limited cost sharing. There's no monthly premiums. There's no deductibles. There's no co-insurance. There's nothing like that. And it offers a wide range of comprehensive services, including primary care, including dental and vision, including mental health and substance use disorder, including a pharmacy benefit. And then another thing that it offers is transportation. for people that don't have cars. Like every plan has to actually give people non-emergency transportation to a doctor's office for even if they don't have it. So how do you know if somebody is enrolled? So we have a lot of resources on this that I can make sure if this is something you're interested in. We have wallet cards, we have flyers, we have a adult coloring book. So a lot of different things that has this, but basically it's now available to nearly all adults 19 to 64 who live in North Carolina with incomes between 0 and 138 of the federal poverty. And this is one of the income eligibilities that has it broken down by monthly. And again, so 19 to 64 and that. And then it gets definitely a lot more complicated when you're talking about immigration status. And I'm not going to get into that now because it does get very complicated. And most people, even who have green cards and the like, have a 5-year wait period till they're eligible for Medicaid, although there are exceptions, and the exceptions are pregnant women and kids that you can bypass that 5-year wait list. And then there's also something called emergency Medicaid. So even that undocumented folks can be eligible for if they end up in an emergency room or something like that. But again, not necessarily important for this group right here. And just also, there's people who are formerly incarcerated. Just an FYI, Medicaid is not one of those benefits that discriminates against people with any kind of arrest, conviction, charge, or history of incarceration, which is very exciting. And in fact, North Carolina has applied for a Section 1115 reentry waiver, which basically 90 days before someone is set to get out of jail or prison, they will actually be able to attempt to enroll in Medicaid. So they'll actually have a continuation of coverage, which is just a very, very exciting thing and can definitely help with recidivism rates. So one of the biggest barriers, and this is where we come in, and this is how we can have these conversations, one of the biggest barriers to enrolling is if people are eligible, they don't believe that they are. And again, this is a copy of one part of our wallet card. And you can, carry these around with you. I carry them in my wallet so you can sort of talk with people about it. And then the other piece is that I wanted to talk about is just so you have this information at your fingertips is how people can enroll. So they can enroll through 2 online portals. One is called ePass, and then the other is healthcare.gov, which is the ACA marketplace. And even though open enrollment, quote unquote, is closed, Medicaid enrollment is open 24 hours a day and all year long, and they are able to now do it through the marketplace in a way that they can be determined eligible immediately. So this is a change starting February 1st
Wow.
that they can be determined eligible immediately, and then they will be enrolled into a plan, which is great. You can also do a paper application and do it through your local DSS. But honestly, that is, I think that through the online portal seems to be the quickest thing. And so the last thing I want to say about this is we are so lucky in North Carolina to have what's called an NC Navigator Consortium, which is a group of organizations and people that will help somebody go through the entire application, whether it be ePass or the marketplace, for free. And they offer unbiased help in filling out the application and answering questions for people to help them get that application done, because it is confusing. There are a lot of questions. And this is just really wonderful. And this QR code brings you right to the ncnavigator.net schedule online page, and people can schedule to be on the phone, on Zoom, or in person with a navigator. And I cannot stress enough how that this is how we're trying to push everyone that is going through Medicaid that enrollment. we're really encouraging people to use the navigators, because it just personally, I tried to help someone enroll through ePass, and I live in Orange County, which has, a very, well-respected Department of Social Services, and I've run into an issue with the person who I've helped, where I don't believe she's actually come back to me with the correct information about what else is needed. And I'm actually waiting to talk with her supervisor about it. So I think there's a lot of confusion. And so the wonderful thing about going through the marketplace in particular is it bypasses now the local departments of social services, and I think can just be easier for people. And I'm going to stop sharing there. So that was just a really quick overview, and I know, and there's a lot more to know about Medicaid, but the couple things I wanted you just to know is that it's an increased eligibility. It used to be, the biggest increase is, it used to be that if you did not have a child, you were not eligible for Medicaid, no matter how little money you made. That has changed. So you can be a person, a single person now, with between that 0 and 138 federal poverty, and be eligible now for Medicaid, which is fantastic. It's going to be huge. It's going to be really big for people in unhoused populations, who many of them do not have dependent children. So it's just going to, or the people, coming, re-entering, coming out of incarceration. Like, it's just a game changer for so many people. And the idea is now, like, we can each be an ambassador for this program, and telling people that there's an opportunity now for, a free or very affordable health coverage, where you're not going to pay more than $4 out of pocket. So that is one thing that I wanted to talk about. Definitely something that we can be talking to people about. Another thing is, and to show that advocacy can work, right? Like, that this was an amazing experience where, even again, in this divided political climate, we were able to mobilize enough people and put enough pressure on our elected officials to and be strategic. We were very strategic about messaging, about all of these things, but we actually did get it done. And so the importance of speaking up, civic engagement, voting, in actually moving policy forward. And that, so I think it's a very sort of empowering example of what can happen when we get involved. Like I mentioned, this short session, we're going to be trying to do something on medical debt. Moving forward, at least put some protections in place, some additional protections, about transparency, making sure that hospitals actually put up like how much things cost, just like very basic things that you're just like, why are we not doing this? To give people protections from harassing phone calls from collection agencies, things like that. Unfortunately, one of the big things that we can do, which is expand charity care coverage, is not in the bill any longer, because the hospital lobbies have pulled it out. But, as we're looking towards long session in 2025, one of the things that one side does better than the other, I will say, conservatives seem to do this better than progressives, is long-term planning. And we're trying to correct that. And we're trying to have long-term planning for the issues that we want to address in the years to come, and really be cultivating champions, for that, no matter what our political, and I think we can win on some of these, even if, it is still this divided political climate that we have. Let me just quickly switch to more of, and I think there's work to be done on these things on a national level as well. So just gonna switch now to, the national federal level and the Medicare for All work that we're doing. So like Wayne mentioned, and he's at our meetings, and there's one on Wednesday, we have a North Carolina Medicare for All coalition. It's made up of over 45 organizations and many individuals who are passionate about transforming our healthcare system to one that is not profit-based, that actually works for us and tries to control costs, tries to address racial health disparities. And our current system that has profit at the middle is never going to do that. No matter how much we tweak it, matter how much, the problem is the bureaucracy, the redundancy, the profit. That's the problem. And until we address those things, we're never going to get truly universal coverage that isn't going to break the bank or be equitable. Because again, mentioned with the medical debt, I mean, you have so many people that are quote underinsured. So they have an insurance card, but can they use it? Can they actually afford to go to the doctor? Another personal example, I helped my friend sign up for Marketplace insurance, and him and his wife do not make a lot of money. They're getting over $2,000 a month in subsidies. By the way, he still couldn't find a silver plan for under $200 a month out of pocket. And that was with a $5,000 deductible and $150 copay for specialists. I mean, how is this a good plan? And they were all like that. I mean, I'm sure if you get a gold plan or a platinum plan, then those things get better, but who can afford that? And again, this is with a $2,000 of taxpayer money going to these insurance companies for that kind of crappy plan. Just mind blowing. So there's a lot we can be doing. And one of the things that I'm looking into, and I don't know what the mechanism is yet, but one of the things that we're looking into is how can we especially leverage the marketplace subsidies to actually put caps on deductibles and copays for these plans, so that while we're trying to move towards what we want, how can we actually make these plans more usable and cut down on that underinsurance number as it stands right now? And so I think that's one of the things that we're looking at. Another thing that's happening, and that groups like Physicians for a National Health Program have really been focused on this, National Nurses United, is these Medicare so-called Advantage plans that are impacting our seniors now. More and more has come out about how these plans commit massive amounts of fraud. There's delays, there's denials, and what does that lead to? People getting sicker, people possibly dying. Also, people that have these plans are facing medical debt because there's a lot of things that aren't covered. It's difficult for them to get out of it. And so this is another, and it's privatizing, right? Medicare, going the opposite direction of where we want to go for a publicly funded plan and a single payer system. And so there's a lot of work that we can do in getting that addressed, which we might actually have wins on. And on the flip side of that, improving original Medicare, because let's be honest, original Medicare needs work. It only covers 80% unless you can afford a very expensive supplement, which a lot of people cannot afford. There's no out-of-pocket cap on that 20% that seniors have to pay. We can work on, some of these so-called advantage plans offer additional benefits like limited vision or limited hearing or limited dental. It's like, why on earth can't original Medicare be offering those? Why are we only allowing these for-profit companies that are doing a worse job and costing us more money to run Medicare, doing all of these things? And I think that these, or, expanding who's eligible, like lowering the age, and pushing more on negotiation for prescription drug prices. So I think there's a lot we can do in this space, and PNHP is really leading the way. One of the things that we just did as the coalition is we met with Senator Ted Budd's health legislative aide, to talk about this supposed love letter. I don't know if you've heard about this, but the insurance companies have been trying to push, the last several years, they've published this letter and tried to get sign-ons by people in the Senate and the House talking about how wonderful Medicare Advantage plans are. And last year, so many House members pulled out of the letter that they actually could not publish a House letter. And so this year, one of the things was to try and stop the Senate letter. And then on top of that, Senator Warren and Representative Jayapal wrote a letter about strengthening original Medicare. And so there's opportunities there as well. So those, and again, the whole time, for those of us who understand that our system is really broken and not working for people, that corporations are really hurting, and these profit-based companies are really hurting our system, to keep also organizing and building our numbers in support of a single payer system. Because I'll be honest, I mean, just the things I'm seeing, I just think our healthcare system is on the verge of collapse due to the pandemics, so many things. There's to the profit-based, you have insane moral injury to providers who are just having to work in this very inhumane system where they're seeing so many people get hurt. And I just think like we need to be ready to jump in and not allow the moneyed interest to be the only people framing the solutions. We need to be framing the solutions. We need to be offering the solutions when that moment hits. And so just always to keep that in mind as well. So I'm going to stop there because I've been talking a lot, but and open it for questions now. And so if people had specific things, I'd love to answer.
Rebecca, how old was your friend who's paying, I guess, $2,200 a month for medical coverage?
He is 63 and his wife is in her 50s.
So there's two people, not one. It's two.
Yeah, so they each got about $1,000 for, for subsidies, available subsidies, and he actually ended up going for a bronze plan instead, and this blew me away. It's not even a copay, his payment for if he ended up in the emergency room with this bronze plan was $2,200.
Wow. Yeah.
Yeah, well, there's no question, unless you fall in the really low bracket where you have the enhanced benefits, that your price, or you're getting a huge subsidy.
But this was the enhanced
Well, he
benefit.
was getting a huge subsidy, yeah.
Right, and he actually fell into that cost savings reduction too. And in last year, I mean, I actually called up my navigator friend and I'm like, I think I did something wrong because like when I shadowed, like, and and he qualified for that when we shifted to silver plans and they counted in, things went way down. And what he noticed, what he told me was, unfortunately, the cost savings in 2024 were minuscule. So they actually like chipped away at that benefit as well. And I think this is the problem. The problem is when the ACA marketplace first started, the plans were actually quite excellent. But if profit is your main motive, these insurance companies are very clever about finding more and more ways to shift the out-of-pocket cost to the quote consumer. Okay. And then so they can be collecting from the government and from the quote consumer. And that's never going to change because care is not at the center. It's unfortunately making money.
I'm going to raise this issue and then go on to let Robin speak to it more. That is, we just had a big get together called Power of the South, run by the League of Women Voters US. And one of the big questions, I guess, issues that were brought up is, do we take our focus off maybe what our local roundtables have been most interested in and shift it to just getting the voters empowered and access to voting? And the issue has come up. The league has been attacked by those who would like to discredit it as a progressive organization that's not really unbiased or nonpartisan. And because of that, as leaders locally, we have to be very careful if, what we say to whom, and only speak with one voice. In other words, say what the league has endorsed already, which is, I think, has its pros more than cons. But I don't know, Robin, you want to say more about what your understanding of that is, and maybe also want to mention a little bit about what Vermont is doing.
Well, I don't know if I can speak to that. Rebecca, I would tell you that the league was right there with the Justice Center back in the early days to get Medicaid expansion enacted. And so we did really good work that I'm really proud of. I would also say as we move towards this new idea of perhaps a national program, which we could call single payer Medicare for all or something else, we really do have some limitations imposed on us from the League of Women Voters US, which disallows any speak to a federally elected official without specific approval, meaning you've submitted a request and had a yes back from the advocacy team at national. And that has been difficult, cumbersome, and actually prevented good work. On the other hand, the league has a very specific, we're always allowed to speak to our positions. And the league has a very explicit position supporting single payer. So while we couldn't go to a federal official and say, we don't like Medicare Advantage, what are you doing about that? We could say, dear federal official, the league stands for single payer, universal access healthcare. And so those principles are in our Impact on Issues booklet that's sent every year, every 2 years, updated at convention. And we can absolutely use that to speak to universal single payer national health plan, Medicare for all, whatever you want to call it. The concept is what we're addressing, that everyone comes into the system. This is what's important to me personally, the same way. You're born, you get a card, you get care. It isn't sliced and diced. You're rich, you get this. You're poor, you're employed, you get employer-based insurance. You're a veteran, you get veterans insurance. The waste that goes into just that accountability of that system. But I did want to mention that because it's such a fundamental principle that I didn't know about until I stumbled upon it accidentally and then got back a lot of negative.
Rebecca, what do you think the factors were that convinced the legislators to, really change course and put this through? We know that we have Medicaid managed care in North Carolina with, I think, about 6 providers of that. And Teresa Bratton, for example, experiences that, and she's working as an allergist, and there are difficulties related to that. But was that the factor that really tipped them over, or any idea?
Well, that's one of the things that they used as an excuse. They were like, oh, well, we couldn't budget it, but now it's, more predictable. I think it was a lot of different things. I mean, one of the things that was another factor was that we at the Justice Center worked to organize the 7 other southern states that had an expanded Medicaid, and we did federal advocacy to include an incentive in the American Rescue Plan for states. And I think one of the things is that with Phil Berger's scheme to zero out the corporate tax cut rate, he needed to figure out a way to bring some revenue in, and so the money ended up becoming very attractive to him on that piece. But again, I also just think it's that we got very strategic about how we were going to talk about it, addressing sort of the issues that they kept bringing up by not repeating their mythology, but like coming up with messages that addressed their mythologies, and change the framing of the issue, really also just focusing it on the death and suffering of real people across the state. The disproportionate impact on rural communities certainly didn't help. I think it did help us, I meant, and sadly, I think also the mental health and substance use disorder crises that we're facing, that were of course made even worse by COVID, also just made this a conversation they can no longer kick down the road. And so I think it was like a confluence of a lot of different factors, but I still do believe that there are ways to talk about certain issues, even if on the surface they're progressive, if we're smart in the way that we talk about them, that we can get pushed forward even in the current political climate. And if things, stay the same, after the 2024 election, which hopefully they will improve after the 2024 election and not actually get worse. But nonetheless, I do believe that there's movement, in particular on things like mental health, substance use disorder, things that are impacting so many people. I think dental is another thing that, and pharma. I think these things potentially there can be movement on. So it's like, it's all about how can we be strategic, and not something that quote unquote progressive organizations have been spectacular about in the past. But I just think like we're getting smarter about these things. Like even on our North Carolina Medicare for All, the last coalition conversation, like we really did talk about how we can talk about, it used to be we're just very purity driven. Like if it's not about, transforming our entire system immediately, like we're not interested in other things. But it's like that's just not reality. And there are things, and the light went off for me when I heard like all these politicians, especially running for Congress, that were talking about a public option. And it's like if your stuff like I do about it, the public option actually won't fix the problem. It actually will take a huge amount of political capital to do for not fixing the problem. It doesn't address cost because it just becomes yet another plan in our multi-payer system. So you're not addressing the redundancies and the bureaucracy and all the administrative cost. And you're going to just have, insurance companies find ways to put the sickest people into the public option, jack the price up and say, see, this doesn't work. So, but politicians think it sounds good. And so like this light bulb went off and I was like, well, how about we try and direct them away from the idea of pushing for a public option and instead push for other things that are wildly popular, like expanding traditional Medicare to include dental, vision, and hearing, or lowering the Medicare age to like 60 or even 55. Things that when they were being discussed as part of Build Back Better, hold the highest out of anything in that legislation. Because again, healthcare is just something that people have had the most experience with, I think, out of any of our issues, direct experience. And they know the system is broken. They know that it's not working for people. And so I just think that with healthcare in particular, we just have opportunities if we're smart about the way we talk about it, and push for it, and sort of the campaigns that we come up with around it.
We've got to have more questions. Who goes next? Rob?
Yeah, Rebecca, I just want to piggyback on what you were saying, particularly about being strategic. Last week, or maybe it was the week before, I did a presentation in Charleston, South Carolina, for their Kiwanis Club, and I did cross paths with Sonia Donnelly. Are you familiar with Sonia? She's the healthcare. She fills Wayne's position for the Charleston Healthcare Roundtable, but she also chairs and runs a nonprofit insurance company that helps people to find coverage. But getting back to your point about strategic, in speaking with groups, I've found that people fall into two categories. The people who are in this Zoom meeting push for healthcare in part because of a belief in democracy and equity. And then you have another large group of people who are looking at their purse or their pocket or their wallet costs. And what seems to get their attention is when I say, in most cases, private business does do better than government in doing things. But when it comes to healthcare, that's not the case because the dynamics are so different. You know, you can shop a house, you can shop a car and compare and do all those things. But with healthcare, because of the fact that so many are on set, you can't go out and shop 3 different facilities when you're having a stroke.
Right.
And you tell your spouse, well, just sit there and drool. I'll be back to you in a half an hour. And even when you can shop, because the way insurance is designed with a max amount of pocket, if a max amount of pocket is $5,000 and that's all you're going to pay, no one's going online to shop to see whether a facility charges 30 or 40 for a hip replacement. So that theme seems to ring home with business owners that, yeah, that makes sense. And we do need to be more competitive when we start comparing costs with other countries and looking at our costs for going into the exchange. So anyway.
Good point. Julie, what did you want to bring up?
Yeah, thank you. Following on from Rob's conversation, I mean, I think that the American health system right now works very well for those of us who can afford health insurance and can afford the deductibles, and maybe also don't have life-threatening illnesses. But the opposition, and I'm all for a single payer system. I was raised in a single payer system and I love a single payer system, but the opposition I hear from people that I know and love is, I like to choose. I like the opportunity to go to as many doctors as I want. I like to have 5 or 6 specialists. I mean, they don't say this to me, but this is the way they use the health system. I like to have 5 or 6 specialists. I don't even have a general practitioner. I go to a specialist when I have a pain in my finger. And they don't want to give that up. I think that if we really want to push for a single payer system because of our faith in democracy and wanting to do the best for everybody in the country, then we've got to address the fact that the opposition is going to come from within. And that's going to be a big problem to overcome, because people are going to have to give up that entitlement.
But they don't give it up now under traditional Medicare. You can go to any doctor you want, and there are very few managed care restrictions. What is true about what you're saying, Julia, is I think the idea of having just one major system and taking people, particularly, I'm not an advocate for the Advantage plans, but if you tell Americans, half of whom have Advantage plans and pay 0, that they can't have that anymore, I think that's a showstopper.
Tim, you wanted to bring something up?
This goes back to maybe the sausage being made at our state level. I'm glad you're there to look at it, Rebecca. I wouldn't want to be there. Thank you. And congratulations on your recent Golden Globe Award.
Yeah.
Yeah, that's really important. I heard about that. One of the genesis is apparently of expanding Medicaid is to save rural health. That includes marginal services that struggle, but they struggle everywhere. Behavioral health, occupational health. Who is monitoring that at the rural level to see if we are getting our money's worth? Is someone looking at the general financial performance, or will be prospectively as we engage with expanded Medicaid, that the rural hospital that may be on its last dollar is actually going to do better? Who is taking that responsibility?
That's a really good question that I don't have exact answer for, so I'll look into it and get back to you. But I know that, for example, like the Shep Center and um, other like departments at Duke and UNC are, working with the Department of Health and Human Services to look at a whole host of different, issues to see how things are working. And of course things are complicated further because it's not like when we expanded Medicaid, for example, we just open it up to, folks, and it's being administered through the state. It too has been privatized into this managed care system. And so we have to deal with, looking at that too. How many people who have Medicaid are being denied or are going through delays or providers not getting paid in a timely fashion? Like there's a whole host of problems, unfortunately, that, come with with this as well. Although, again, the fact that more people are going to at least have access to a health coverage insurance card that actually, outside of things like dental, which it's definitely more difficult to find a dentist, but for the most part, almost every hospital system, every community health center does take the Medicaid card. And so more people are able to get, preventative care, see a primary care physician than ever before. And like I mentioned earlier, like especially with certain populations, like those coming out of incarceration or people that are unhoused, it's just a game changer in so many ways. And this is the complicated part, right? It's like very few things are just like super just 100% positive. There's other issues that come up within the positive change that also need to be addressed, but that doesn't mean that the whole thing should be thrown out. It's just like, at least in terms of right now, until we have like, the bigger change, which is just transforming our system so that we're all on a truly equal and equitable level and all have the same coverage. And in terms of the choice, it's just really interesting that you bring that up, and not really, because Wendell Potter does a whole like thread on the fact that they actually knew that limited networks that are offered by the insurance companies are actually one of their weak points. And so they actually went on the attack, on the offense, attacking single payer for lack of choice, where the lack of choice really for a single payer system is not in your choice of providers, but it's in your choice of, quote, insurance companies. But that all gets very muddied. But they knew for a fact that actually, in terms of private insurance, choice is actually their weakness. Because you do have these situations, even in the same hospital, where this anesthesiologist isn't covered, by your insurance for this in-network facility, and things like this. And it ends up being very complicated. But I just think also people are just, again, they inherently understand that we have an overly complicated, I have to say, I do this for a living and I'm constantly amazed myself. When I hit on a little nugget of something where I'm just like, how are people not in the streets about this? Like, why is this okay? Like, why have we allowed like this to be okay, that people who have cancer are losing their life savings, that hospitals up until very recently were putting liens on people's homes or suing people because they weren't getting like their bills paid, or putting people in collections for harass. Like, why is this okay? Like, why are we okay as a nation and the richest country in the world to have our healthcare system be doing it this way? And I have to say, one of my most disappointing things is that we weren't able to create the space during at the height of the pandemic. And yes, we're still in the pandemic, but at the height of it, that we weren't able to create the space, especially when the vaccines and things were given and the testing was done for free. How we weren't able to capitalize on that moment to really push for a situation where, that look, healthcare can be this way. Whoever needs care can get care. Like, why is it, only for this one thing and not for people with all these other things? And that's one of my biggest sadnesses that, you know, that we weren't at a place where we were mobilized and organized enough to really, and plus we were all traumatized, also, and cut off from each other in a lot of ways. But it's just a missed opportunity. But again, sadly, I think the opportunity is going to arise again because our system is just not sustainable. And again, when I saw the marketplace plans this year, I was stunned by how bad they were. And honestly, if you have money, it's worth it to actually go outside the marketplace. But oh, one other thing that I wanted to just mention, since you all are, you know, sort of very knowledgeable about these things, is one of the hidden things that was in the state budget was actually pushing our insurance commissioner, Commissioner Causey, to look into creating a state-based exchange. So to actually get us out of the marketplace and actually get us into a state-based exchange. And actually, we're working with a group called US of Care that have a whole one pager that talks about how this actually could really benefit our state, and that it can actually allow us to actually offer better plans and have more control over that. Because I wasn't sure about that. I was like, ooh, that I wonder. But they were like, no, I mean, it actually gives the state more flexibility to offer better plans. So that's actually very exciting. And stay tuned. You know, we're gonna get more information about, you know, because I'm sure there's public comment periods and things like that that will be coming up once a plan is developed, you know, just you know, to do that. And so obviously I'll keep everybody in the loop on opportunities like that and talking points.
There is one hard point that expanded states have accounted for, I think, pretty well, and that is about a third reduction in medical debt going forward from the time you implement it. Makes sense. Because basically, Medicaid expansion is a funding mechanism. So when people grapple with medical debt and try to wrap their head around it and get a migraine, they realize how you take care of it.
Yeah.
You
Yeah.
direct, anyway, you direct the funds to where they're needed.
May and Jean, I wanted to give you a chance to tell us what other organization you're involved with and how it might coordinate with the league. Am I putting you on the spot?
Well, it's a community foundation, Greensburg Community Foundation giving circle, and actually Robin is chairing it. So Robin, why don't you talk for May and myself and you?
Thanks, Jean.
The Lane Square has been very noisy.
I'll
Oh,
just
that's right.
say,
I forgot. Yeah, Tim's also on the giving circle.
thank you, Jean, and thank you, Wayne. I'll be very brief. It is associated with the Community Foundation. Its purpose is to be an equity ally to groups that are already in the Community Foundation, one of them being BIG, Blacks Investing in Greensboro. We are trying to use a new way of looking at philanthropy, foundation funds called DAFs, or just individual donor funds. You're welcome to learn more and contribute if you'd like. We meet as often as we can to talk about how to turn this very big ship of traditional philanthropy around to a more justice-based form of giving. So at this point, we have about 16 members in what we're calling a leadership group. And I will tell you the thorniest issues have to do with the issues of equity, undoing some of the harms of racism, which May and Jean can talk to some more. But I want you to know that this really is an extension of the league's work, because while I felt I couldn't speak as I wanted to within the league because of that one voice, one league policy thing that kept saying no, I took troubles and went elsewhere. So this is a trial of a different group, and I think all of us together can make a difference. We have to impact this, Rebecca, whatever way we can. You cannot do the work alone at the Justice Center. We can't do it through our giving circle, and the league can't do it without a lot of help as well. So I'll send on any information anybody wants. We're always open to donors, and those donors then can impact our work.
And I'll just add, and maybe Robin, you said it and it went by, that the Giving Circle chose for our first, I don't know, project, whatever you want to call it, medical debt, and how we can impact some way, not just to I just went to a Racial Equity Institute, not to feed the fish, but how we can help the groundwater and the lake be cleaner. So that's how this intersects for me today.
Exactly. Thank you, May. That's really important.
Well, I would love to hear more about that. So Robin and whoever else is working on that, maybe we can do a short just meeting another time, just to sort of talk about what you're thinking about, because passing this protection, if we can, in the short session, like this is a long-term campaign, and any ways that we can be working together is a good thing.
Thank you very much, Rebecca. We've just run out of time. I'm going to stay on a little bit longer if other people want to. For example, Carolyn Bunker is kind of trying to connect with me, but I would like to have the next meeting live at Deep Roots, if that's okay with everybody. Jane's not going to be available to do the Zoom, and I just think it's nice to get together face to face once in a while anyhow. But that is going to be on March 4th at noon. Any issues with that? Can't hear you, Barbara.